Welcome to this episode, everybody. I am super excited to reintroduce you to Jerry Hesch. Jerry's back again for another episode with us. We're going to be talking about the pelvis and his journey into developing his body of work that is absolutely amazing. So Jerry is a physical therapist here in the Denver or the Colorado area. He's also the founder and he created the Hesch Institute and the Hesch body of work, the Hesch method body of work. And welcome to this episode. Welcome to the podcast, Jerry.
Thank you very much.
Yeah, I love our conversations. Can I just start off with that? Because
Sure.
I think I've shared this before. Your body of work really did transform my practice in the way I approach the low back sacroiliac joint pain. And so I was just curious. I thought it would be fun to kind of introduce people to how you developed your current body of work. So how did you get into body work initially?
Well, let me start by saying I'm a middle child of a large, loving, hating Irish Catholic German family.
Oh, good Lord.
So I always questioned the norms. Okay.
Yeah.
So when I learned about manual therapy techniques and have studied from many of the great ones, and I've read much, 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 I've always questioned it. Well, why does it have to be this way? Can it be different?
Yeah.
Cuboid's a perfect example. Everyone's still talking about thrusting the cuboid from bottom up, but most stuck cuboids actually are stuck in a supinatory pattern and they need the opposite. And then we go a little bit deeper. Well, what controls the cuboid? The navicular does. And so if the midfoot is very restricted, you can free up the cuboid without touching it. And it has a direct connection to the calcaneus. And if the calcaneus loses transverse plane mobility and you restore that, bingo, cuboid is happy. So that's an article I need to publish, but that's one example of how I question the norms throughout the body.
Okay. So how did you, because you originally were focused on the pelvis, weren't you, or not so much?
Well, in a sense, I mean, honestly, I started treating all joints and had a great mentor, in treating the whole body, but I had, more focus on the pelvis. Yes.
Okay. Because that's, I guess my assumption of that is because that's the course I took from you. It was,
yeah, I've done some really good work on foot and ankle. First rib, I treat it very differently. Upper cervical, I have some very original work, but yeah.
Okay. So you're questioning your curiosity and questioning the norm. That's really how you've gone about developing your body of work and your approach to the body, which I love because I think that's what I've kind of done as well. It's just gotten curious with what am I seeing in my hands? What am I feeling? What's going on in here? So tell us, how did you, because I feel your approach to the pelvis is really unique.
It is. It's extremely unique.
Yeah. And it's super effective, super effective.
Very quickly lasting, because I followed up with these people. I followed one guy for 5 years. I'm like, it's good. He's good.
Yeah. So, how did you discover that? How did you go about? Wait, before we go there, I just want to preface this with in PT school, I'm not sure what chiropractors learn or what other osteopaths learn, but in PT school, really our only assessment of the SI joint was the standing stork test, where we have one thumb on the PSIS and the other on the sacrum, and we're trying to see if it can move. Really? Like, that's what I remember learning in the SI joint.
So study after study has shown that with that test, because the SI joint is already loaded, even if I flex my right hip and knee, okay, I still have upper body weight going through the joint on both sides.
Mm-hmm.
So actual movement in the SI joint is sub-millimeter.
How can we palpate that?
Thank you. Further to that, let me say this. 30% of people have asymmetrical development of the pelvis. It's bony. It's not something we're going to align. Okay?
Yeah.
Now, how many people have differences in the development of the hip, of the knee, of the talus, of the calcaneus. And then you do this test where you lift up one leg and you're saying, this isolates the sacroiliac. I don't think so. I've never found that to have utility, but some people, that's what they're taught, and that's what they believe. They're not exposed to other approaches. I've seen 2 articles published in the last 3 years or so. Okay, I believe in the last 3 years, one in a chiropractic journal and one in a physical therapy journal. Okay. And they both make these glorious assumptions that the test validates sacroiliac motion. So we don't need to worry about that. I'm like, where is the gold standard? Guess what? There is no gold standard. It has not been compared to, anything to show that we can perceive such a small movement. Now, the PSIS is right behind the center of that joint.
Yeah.
Okay.
Yes.
So if you have these 2 iliums, okay, and one of them rotates 0.5 millimeter, and you're feeling the bumps, how much excursion would you really feel?
Yeah. Well,
Again, it's based anyway. We can debate that one later.
Right. No, we don't want to go. But
I'm not saying don't do it. Okay, it may have some value. Okay. But it doesn't correlate well with what I find with my testing with the body sitting, prone, and supine.
And your testing is bringing spring testing that we do to every other joint in the body. We mobilize it. We make sure it can move. We look at its end range mobility. And you brought that to the pelvis. So how'd you develop that?
Okay, so let me first back up to when I was 16.
Okay.
Or 17 or 18 or so. I was on my way to being a state wrestling champion, and I got there, but certainly sustained injuries to my active childhood and such as well, So heard about Rolfing when I was 16, honestly, and I started it. I mean, I was working for a minimum wage job and paying for $40 an hour in 1972, 73, yeah. And so anyway, I had a rib injury, a rib joint where it articulates with the transverse process of the vertebral body. And it was probably rib number 4 or 5, And so I went to the Rolfer and he did his thing and I went back the following week. I said, I still hurt there. And he was very dismissive. So I learned something very interesting, and he said, like, we already worked on that. I'm like, oh, so that's all you got then?
Right.
And I thought, I want to do better than that because I wanted to be a rolfer and I want to know when do I refer to someone else. I want to be responsible. And manipulation didn't help it either. So I thought, well, So I went home. I got a baseball. Okay. The small one.
Yeah.
Okay. A softball would be too big. And I laid on the floor. And I had to find what was the angle in which I could position my body where I would feel that sweet spot of release. Okay. And it was a gentle force because it was only my body weight on that. I'm laying on my back, right? So maybe 8 pounds, I don't know, And then I sustained it for a long time. I think it was longer than 3 minutes. And, I felt just kind of a constant, steady release. And so at age 16, I learned the basic tenets of my approach, which is number 1, based on the person's individual anatomy and with consideration for normative anatomy, find that sweet angle where motion can be gained. That's where you can treat it. Then use a fulcrum. In this case, it was a ball, and sustain the force for a long time. 2 minutes is a minimum for any of my treatments. And I have a few I have one that's 5 minutes. That's the pubic joint because it's a very strong joint. And then I also have a pattern for a posterior glide sacrum I discovered. And that one, it's a pure posterior glide fixation. And that one I take 10 minutes. Otherwise, most of my releases are between 2 and 3 minutes.
And I want to just say that posterior sacrum it can be very common in our postpartum population. The way
Indeed, and a fall on their bum as well.
Okay.
Yeah, right. And it really locks up the whole body.
Oh.
Their entire body will be very rigid.
Mm,
you know,
yeah, yeah, you can feel that in
and
the,
it's a one-time correction,
yeah,
once and done.
that's what's just so
So
fabulous.
then I went to PT school, and honestly, my intent was when I went to college is that I wanted to have a more solid foundation to become a rolfer. Okay.
Okay.
But so before PT school, I took psychology of disability, or sociology of disability. I don't know, one of those
Yeah,
two, right?
yeah.
Loved it. I'm a closet sociologist, And so anyway, I was really intimidated by the process of applying to PT school, but thank God males were in the minority and I actually got in, and I think everyone thought I was probably least likely to succeed or least self-confidence. And, then I did a study on raising hips above the knees and sitting postures. And I developed a seat wedge in 1980, 81. And validated, yes, that is, whatever the posture is that lets pelvis rotate forward and backward more freely is the ideal posture. And they thought I was nuts. Like, what does that have to do with physical therapy? I said, everything. I paused a long time. And I said, our patients come to us with back pain, and then they go home and get in their chair or go to work and sit in their office all day long. So anyway, so my first job was in a really small community in Montana that had a wonderful med library. And I worked with an expert on the SI, and that was Richard Antigny. And I would go swim at night and then go to the library. They had wonderful journals for a little community. Oh my God. And they just really wanted to support the medical community, And so I read very, very quickly on, I read that the sacroiliac joint is a shock absorber. So I thought, oh, okay, well, how come no one tests it like that? And so
Stop
I
right
thought,
there. Stop right there, because that's
right,
huge, Jerry. That this is the foundation of your work. The
precisely,
sacroiliac joint is a shock absorber. So why
precisely.
aren't we testing it that way?
To this day, it's a mystery. It's an absolute mystery, you know?
Yes.
Um, and I know how to test my truck. So when I go to the truck, I push down on the fender to a stop point, take up the slack, and I use the same amount of force to then spring the structure. Okay. If I had to do a semi truck, it'd be a lot more force. Maybe
Sure.
Arnold Schwarzenegger or a TV wrestler would do it.
Yeah.
And if I did it in a little tiny, those little tiny cars, I
Yes.
don't know,
Yeah.
smart cars,
Yeah.
then I
Yeah.
would use a lot less, right? So I adapt it to the structure in front of me. And very quickly I discern what the body type is like because I spring a few joints before I get up to the pelvis.
Got
So
it.
I push down to take up the slack, and then I thrust it with about the same amount of force, but I keep the load there so it bounces back into my hand. That's the recoil.
Okay.
I
And
could never go back. Our tradition of orthopedic manual PT to this day is take up the slack, and you're going in a specific direction, of course.
yeah.
Take up the slack, then thrust it and grade that motion.
Mm.
I'm like, I become a plumber if you took that away from me. I've got to feel the recoil. And you're going to feel a few things. Number one, in a normative structure, you're going to feel the ability to take up the slack, spring it, and it will recoil with integrity. Normal. Bingo. Move on.
Yeah.
I am not into little grades. Oh, that's a little hypo, or that's a little
Yes.
bit hyper. I'm like, that's not what the money is. The money is where there is a distinct phenomenon. Okay. The other day I had a person that didn't know. I mean, she'd been to the ortho twice and had MRIs and was sent to PT twice. And I'm like, she's got damage to two of her ankle ligaments.
Mm.
You need more than what they're giving you now. No one had given her an ankle brace. I mean, no one even picked up on the laxity.
Yeah.
Ortho didn't do a hands-on assessment. So she did have distinct laxity in the ankle. Okay, well, that will get the biggest bang for the buck if we put her in an ankle splint for 6 weeks or more and do rehab specifically to that. And at the end of that, if it's not really improving, I think then that's an orthopedic surgical procedure.
Right. Right.
But there's a secret. in the body. If a joint gets stuck in one direction, and you do the spring test, it'll be blocked. You can't take up the slack,
Right.
or it'll take up really quickly and then you can't spring it. Okay.
Yeah.
Very distinct. If I go push on the brick wall, it's stuck.
Right.
Okay. But
Well,
if I go like in the middle between two joists on the wall, there's a little give on the wall. Hunter, Lola, sorry, those are the doggies.
No.
That caused me to lose my train of thought. But yeah, stuck is very distinct. Now, if you have a joint, there's excessive motion in one direction, what'll happen is it feels like it takes longer for you to take up the slack. And you truly must take longer for that population. You know, the hypermobility, the Ehlers-Danlos people. Yeah. So it takes up longer, and then you spring it. It seems like it goes further, and it just doesn't recoil with integrity. It's kind of like mush.
Yeah.
You know, that's hypermobile. But always go test the opposite direction, because sometimes in the opposite direction they lost movement. So the joint integrity, you know, one structure moved in another direction and stayed there. And it can actually go further. It has a propensity to go that way. It just requires a passive, gentle, prolonged force in the right direction to restore that. And there's all kinds of neurophysiological things that go on there and balance the muscle tone as well. And muscle is a profound secondary stabilizer. So sometimes restoring movement in the direction it's stuck fixes the opposite direction of so-called hypermobility.
Yeah.
And sometimes, sometimes you can't take up the slacks, bingo, you know, it's stuck, or it takes up quickly and then you can't spring it.
I rarely find that one, Jerry. I find usually when you take up the slack, if that's restricted, the springing is restricted as well. That's the most
exactly. You get early info.
You know,
it's an easy tool. People can develop that skill in a matter of minutes.
Right.
But it does take kind of a focused attention to the matter. You can't just quickly load something and spring it. No, it takes about 3 seconds to do it correctly. You know, you have to find the anatomical part, know which direction you're going to test, push to take up the slack, spring it, feel the recoil. Rob Shapiro is a certified Maitland therapist in New York, and he studied my work and he loves it. And he calls it springing with awareness.
I love it. Yeah. How did you
just slowing it down?
How did you come up with the directions of the mobilizations that you put on the pelvis?
Oh, well. So way back when in 1981, when I was studying the, Don Tigny's approach and then delved into the traditional model, and, and then I started doing my spring tests. And I would go through those things and I would still feel like I'm not getting this pelvis correct. My palpation tells me there's more ligament tension. Why? I'd go home, I'd get the model, and I would take just a sacrum and what are all the different ways it can move about 6 degrees of freedom? Okay, an AP axis, a vertical axis, and a transverse axis. What's every way that can move? Now add an ilium. Now what happens? Okay. Now add another ilium. Now create movement in the pube. I mean, I found 2 patterns in the pube that like no one knows about, and they're very common. The osteopathic model, I'm sorry, it doesn't palpate enough. You have to palpate lower pube, and the osteopathic muscle energy technique doesn't do spring testing. So, anyway, I trusted my hands, and I would go home and say, well, what else could be going on? And I went on to discover 18 movement patterns in the pelvis, in which you can develop restrictions, treatable restrictions, and they're not in anybody's books. They're not in the chiropractic literature. They're not in the osteopathic literature. They're not in the PT literature. And I always have to count them because I'm like, that seems like a lot. That seems crazy. But honestly, within 1 to 3 visits with a client, if they have something highly unusual, I will find it. Last week, I had somebody with a vertical fixation of the fibula. I find that every 5 years. My
Mhm.
son had it. He had to quit training. I fixed it in one visit. He resumed training and he won first place in the Albuquerque Luz mountain race.
Nice. Yeah.
So, by doing the spring testing, I can find the weird, like, well, that's still not working right.
Right.
There's something,
Well,
the joint's
and,
talking to me.
and you're comparing one side to the other, right?
True. Absolutely. So you
You
have
know,
a norm.
so I think that's the
Yeah.
biggest thing that I took away from your course. I took your course in the mid 90s, and I just remember you saying that the bone should have some spring to it. Like you were palpating the femur bone, right? And then the tibia.
Oh, yeah. Yeah. Yeah.
And you're just like, there should be some give to the bone.
Right.
And that was just like the first time that I'd really ever even thought about that. And that's just, and then I just saw how you were kind of compressing everything and you're just like mobilizing everything. So I just started taking that. And that's like my approach to the body is just feel what it feels like on one side, feel
Exactly.
what it feels
Find the
like on the
norm
other.
for this person. Yeah.
Yeah. And
Yeah.
then treat if it doesn't
I could blindfold you and then I could give you 5 very different body types and you would find where in the body they have a mobility impairment.
right, because I'm comparing side to
Yeah.
side. And you can totally tell a difference. And
Yep.
Jerry, I'm not as detail oriented as you are. I really appreciate that about you. I just kind of I use compression, I use mobilizations. I also use my intuition a lot and just let
Yeah.
the body take me
We
where
should be
it
that.
wants to
We
go.
should be intuitive practitioners. And intuition isn't some psychic ability, it's pattern recognition based on your history of doing that repeatedly. Nothing magical, but it's very utilitarian. Oh,
I,
that's woo-woo. No, I don't think so.
I
I think
appreciate
it's
that.
science. It's science.
Yeah, yeah. It's that inner knowing of
Right,
this
right,
is what needs
right.
to happen here, right?
Correct. And
Yeah.
you affirm it with testing.
Yes.
It's not like
Yeah.
you just say, oh, I need to do this with you, wow, wow, wow. No, it's not that. It's let
Yeah.
me then confirm it or negate it.
And you know what I also really appreciate is helping my clients feel the difference, right?
Yeah,
In
yeah,
helping them to see, can you feel how this side moves? Can you feel how
right.
this side moves? Do you feel a
Yeah, and the
difference?
story changes. It changes from, oh, I need a lot of treatment, and that's what they're used to. And it changes to, do you see how that opened up, that movement?
Yeah.
And when
But
you
not even,
come back,
yeah, it's feeling
I'm
it.
gonna I'm gonna show you it's still opened up.
Yes.
And
Yes.
a week later, I'll show you it's still opened up. I only see people 3 times typically.
Yeah. Yeah.
And you can come back anytime you want and I'll show you. And here's a
Well,
simple thing you do for 2 minutes once a week so that you are confident that it will stay. But know this, every time you walk now, your body moves normally because that mobility has been opened. Your body has a greater wisdom than we do.
amen to that one.
So, but the other piece the other thing that makes me just love manual therapy, let me do this by illustration of an example. So somebody comes to me and they're frustrated, of course, and they've had 3 months of spinal stabilization exercises. Okay.
Yeah.
I go test their strength. They're weak. Their core is weak. Okay.
Yep.
Let's say their trunk is weak in rotation. Okay. Why is it weak? Well, because some joint somewhere in their body is oriented the same direction in the lower body, pelvis, hip, on down. There's a restriction there, which makes the lower body, let's just say arbitrarily, the lower body orients to the left. Well, then
Okay.
the upper body has to counter that and
So,
it will rotate to the right. So the body will test strong going to the right. To the right is facilitated. Then you test them going to the left, upper body is weak. You can test their head, their upper cervical rotator, C1. Okay. Even if it's a stuck cuboid or a hip that doesn't rotate or a pelvis that's twisted. And long ago, and then you correct it and then you retest. It's like, oh my God, look how strong that core is. It wasn't weakness, it was inhibition.
Say that again, because that's
It
so
wasn't weakness because 3 months of core exercises did not work.
And as soon as you corrected it, you get strength. If it's true weakness,
Exactly.
it wouldn't
Yeah.
improve instantaneously.
And now every time they walk, again, their body finds that, finds that movement. And so it's like self-reinforcing. It's a
Absolutely.
very, it's a very different model. And I'm just a solo practitioner. I always have much on my plate. I'm juggling much, and I am a disabled person. I have limited energy in any given day.
Yeah.
And that goes way back, way, way, way back. So neurological insult. That being said, I hope that someone else will help carry this work forward. I do have some people that are helpful. But yeah, we need all the help we can get.
Yeah.
And,
Well,
our profession needs to wake up. Forgive me, I'll
yeah.
apologize in advance, but our profession needs to understand that weakness can be a neurological inhibition because of a lack of micromotion, and restoring that micromotion immediately removes that inhibition, and the person is bingo, stronger.
Well, so Jerry, I'm right there with you. I may not be promoting everything that you teach. I'm promoting some of it. So I've been
Yeah,
referring
yeah,
people to it, okay? But I get the same results.
yeah,
When
exactly.
we have what I call the open birthing pattern, where the ischial bones splay open for a baby to come on out, and it remains that way, sacrum is in flexion, we have pelvic floor muscles that are on stretch. They
They're
are
altered. Absolutely.
lengthened,
Absolutely.
right? And so
And
just
that's
like you,
validated objectively. We know this because of x-rays.
yes,
If a woman goes to the doctor, let's just say the doctor didn't know her history, but just glances at her pelvic AP, maybe an orthopedist. They will look at her pube and say, how many children have you had? That's where the history is, right there.
because the symphysis pubis joint increases if you've had a baby. So instead of being
Absolutely.
2 millimeters, it'll be wider than that. But
Absolutely.
But the point of this instantaneous strength change is when
Yep.
you learn to bring the bones back together to their original position, those pelvic floor muscles are instantaneously stronger.
Correct. And guess what? If you say, well, there's so little motion in the SI, how could you discern that pubic bones are more lateral, in a female? Well, first of all, you do it with spring testing.
Yep.
Okay. So you won't be able to load it. You won't be able to spring it. Bingo, it's stuck. And then you do an intervention, then that changes. But please understand this. The midpoint of the ischial tuberosity is at an angle to the mid part of the SI joint. Okay. So a little tiny movement in the SI joint is reflected in a much greater movement at the ischial tuberosities. And there's also movement happening in the pubic joint with that spread of the ischia. So we need to understand, those geometrical relationships.
Absolutely. And when the ischiums are splayed, they have decreased mobility medially.
Right.
I can
Yep.
appreciate that. And so that Jerry, thank you. Thank you for validating everything that I'm finding in the body, because you just kind of reiterated it right there that when
Yep.
the ischiums are splayed, it impacts the sacroiliac joint, it impacts the pubic bone, and
There'll be an inhibition somewhere else in the body. Go higher up and you'll find something up there is also inhibited. People tend to think, well, if you lose motion in one place, you'll gain it. And that's certainly true in my neck. But another phenomenon happens is that somewhere in the body, it also reduces motion. So when you walk and your subtalar joint undergoes goes into pronation, there's a knee version in the calcaneus and also transverse plane abduction. Okay. Now, if through trauma or habit or whatever you lose that movement, okay, well, somewhere in the lower kinetic chain, you're going to have to gain some motion to compensate for that. Hip is a great place to do that. Minimal stress on your body because it has a great amount of rotation. But guess what? In the C1, C2 joint, you will instantly get reduced rotation. Or reduce rotation to one side if it's only one subtalar joint that's restricted. So yes, it's true that you'll gain motion somewhere to make it up, but the other half of the story is you're going to lose motion somewhere distal also.
Yeah, yeah.
Let me give you a quick case on that. Treated a patient's husband, and he had 5 years of headache, and he lacked hip internal rotation, and he lacked mobility in the ankle and subtalar, and his neck was like steel. And so I knew, like, I'm not going to succeed if I work on his neck. It's coming from somewhere else. It's reflexively driven. Unlocked hips, unlocked feet, boom, neck melted. His muscles felt normal. And 5 days later, he sent me an email. He said, I'm headache free. He had severe headaches for 5 years. So understanding those relationships is really important and it really facilitates ease in our interventions. And I do have a whole body, work.
Yeah.
Not just SI.
Right. So you have a whole body approach, you have the pelvic one. And I just have to say that your approach to the body is just so brilliant and it's so easy.
Yeah. And thank you. But you know what? I never sought out to be an expert, not much confidence. Okay. Until I know something, then I'm confident. But my purpose was to understand the body. That was it.
Jerry, I have to say that's the same with me. I never saw myself in creating the Institute and being, this postpartum pregnancy expert out in the world. But when you find something in the body and it works and it helps people, you can't help but become passionate about it and want to get the work out into the world. So I thank you for developing the Hesch Institute, the Hesch method of treating the body, because it's brilliant work. It's definitely informed my practice and what I'm out there teaching. And so I just encourage everybody, please, you can check out heschinstitute.com. And I also want to just say that I have put together a treatment of the postpartum pelvis online course that is just about the pelvis and how to close up the common postpartum patterns that I'm finding in the body. It includes the posterior sacrum, Jerry, so thank you for that. And there's a couple of just a couple of techniques that I've learned from Jerry that I've included in there. And so, but there's a lot of other things that I've discovered and developed over the years that I find are really effective. So please check out either that course or Jerry's courses. We don't care. We just would love for you to be able to approach the body in this manner because it's so effective. So effective. So thank you, Jerry.
Yeah, thank you. And within a couple of weeks, we'll release a new coccyx course.
Ooh, cool.
Yeah, and we're redoing the whole body material as well.
Okay, awesome. Well, thank you everybody for listening into this episode. I hope you've gotten some golden nuggets that you can take into your practice and just start springing the body. Spring one side compared to the other side, and then get curious. Stay curious and open with what you're sensing in the body. All right. Thanks everybody for listening in. Here's to smoother bursts and faster recoveries. Take care, everybody. See you on the next episode.